Hello, this is Dr. Kim Jongjol. Today, I will lecture on the second cause of environmental causes. Following the last lecture, the fourth is ENT problems. First, you have to check if there is a nasal septum deviation with nose problem. But if there is a nasal septum deviation, it can be difficult to breathe through the nose. Next are hypertrophic adenoids. Adenoids are located in the throat wall and are observed near the PNS. Adenoid is pharyngeal tonsil, and McNamara measures the shortest distance in this area and judges that adenoid is large if it is less than 5 mm. How will large adenoid react? The anterior growth of the maxilla and mandible is limited. In the picture, the patient above has adequate adenoid and the mouth is well closed. In the picture below, large adenoid is observed and the mouth is open. In patients with enlarged adenoid, obstruct pharyngeal airway space with mouth breathing are observed. The A and S of palatal plane is upward and the P and S is downward, showing negative values. Next is hypertrophic tonsil. Tonsil looks radiopaque on the below of soft palatal. If the tonsil is large, the posterior growth increases and the anterior growth decrease, which causes the mandible to grow forward. The tonsil size measures the radiopaque amount of the soft palatal. If the distance between the mandibular border and the line where the tongue goes up and the posterior wall is more than 18 mm, there is a possibility of anterior position of the tongue. The mandibular is located forward, or the enlargement of tonsil. Therefore, you should observe whether the tonsils are normal or enlarged in the picture. When tonsil is enlarged, the block of airway, the lower position of the tongue, and the habit of thrusting the tongue are observed. In addition, severe enlarged tonsil can increase the lower arch width, increase the mandible steepness, and affect the mandible prognathic and pronunciation. Let's look at a case. There is little crowding in the mandible, and the anterior crowding is observed in the maxillary. This patient is long face with class 3 malocclusion, and we can observe crossbites in the anterior and posterior area. In the picture, the adenoid is large, the tonsil is large, and the tongue position is also low. This patient has a normal adenoid, a large tonsil, and a poor mouth close. This is a patient associated with class 2 malocclusion. If the mouth is open and the tongue position is low, the posterior teeth can develop crossbite and mesial angulation. Extrusion and occlusal plan have the possibility of diversion. Due to these phenomena, if the molar extrusion is performed in a denture pattern, the pattern of malocclusion will change depending on whether the lip seal is good or not. In normal growth development, when the maxillary posterior teeth are extrusion, if the lip seal is good, the mandible can grow well forward. However, if there is lip incompetency, the mandible can grow backward and become class 2 malocclusion or open bite. In other words, these malocclusions are caused by the backward rotation of the mandible, retrognathic men, high angle, the mesial angulation of the molar. Once again, let's summarize the malocclusions associated with breathing. The malocclusion associated with the mouth breathing is buccal segments cross bite. Open bite or open bite tendency, class 2 high angle, retrognathic mandible. The facial profile is what would look like These are long face, retrognathic face protrusion, and prognathic face. Among them, the long face, retrognathic face, and protrusion are almost similar. And the prognathic face is a class 3 face with protruding mandible. How does it affect the TMJ? Clicking, locking, degeneration of condyle, and/or surrounding structure, and so on are observed. In summary, if you do not close your mouth well and open it habitually, the position of the tongue is lowered. The head posture is extended, and the mandible is rotated backwards. The reason why patient open mouth is because they can't breathe well with nose. And the reason why they can't breathe well with nose is because of narrow upper and nasal septum deviation, rhinitis, and large adenoid. The patient in this picture had a large adenoid and tonsil, so they transferred to ENT and consulted and needed surgery. As a result, they were able to observe a good airway by doing adenoidectomy and tonsillectomy. Adenoidectomy will reduce the size of adenoid, and the nasal flow will be decreased at this time. Nose breathing will be easier. The tongue position will go up, and the lip seal will work well. This will lead to good responses such as an increase in maxillary arch width. The next is harmful bad oral habits. In the prenatal period, figure-sucking habits are said to be human habits. However, reactions that may occur due to figure-sucking habits can lead to protrusion of the maxillary anterior teeth, narrowing of the maxillary arch, and class 2 malocclusion with a high palatal vault. According to the mechanism, the large overjet due to figure-sucking habits. And when the mouth is open, the maxillary anterior teeth are protrusion. And with the lower lips cushioning, the mandibular goes backward and shows the class 2 malocclusion. Therefore, class 2 malocclusion occurs if the habit continues from figure-sucking habits to mixing teeth. If there is a lip bite at this time, the malocclusion will worsen. If a patient is observed with a local open bite or a chipped incisor edge, check first to see if there are any bad habits such as nail or pencil bite. Next is the functional shift. Figure A is a class 3 malocclusion anterior. A 3 is in functional class 3 with a good skeleton, but a cross bite due to premature contact. And A2 is a skeletal class 3 with a cross bite due to anterior movement of the mandible. Normal growth development is the growth of maxillary first, and then forward growth to the end of mandible to the end. But for some reason, mandible sometimes can't grow forward. First of all, if the intercanine width of the upper and lower is narrowed, some patients may become class 2 malocclusion due to doesn't move to the forward growth of the mandible. And some patients may have crowding in the lower anterior teeth. If there is crowding in the maxillary anterior teeth and palatal erupted of the lateral incisors, some patients may occur crowding of the mandibular teeth. Or some patients may have difficulty in forward growth of the mandible due to palatal erupted lateral incisor. In this case, the mandibular can move forward by first putting the upper lateral incisor into position. To know this, model analysis is necessary. This patient is deviated of midline to the left side, right side is normal, but left side is observed cross-bite. When you correct the midline of the upper and lower and observe, you can see the posterior teeth is narrow. Therefore, this patient appears to have become functional shift due to narrowing of the upper and lower arch. Patients with these functional shifts first try match the midline of the upper and lower, and canine class 1 relationship, and then should check where part of the interference. So far, we have looked at the environmental factors that cause malocclusions. Patients with open bite, class 2, class 3, and midline deviations during malocclusion must check the following environmental factors before orthodontic treatment. In other words, habitual mouth opening, tongue position, tongue thrusting habit, ENT problem, oral harmful habit, the functional shift, and so on. In particular, patients with open bite, anterior cross bite, posterior cross bite, and midline deviation must check the airway and tongue position by observing the adenoid and tonsil through the sieve. Thank you for watching.